Hello, everyone. My name is Dr. Melissa Nyman, and I am the Global Medical Affairs Manager for the Negative Pressure Wound Therapy portfolio at Cardinal Health. I will be joined today by a trailblazing group of clinicians representing several Canadian communities. They will review the principles and applications of negative pressure wound therapy and share their experiences treating complex wounds using a canister-based disposable system. But first, I'd like to take a few minutes to give an overview of the Cardinal Health negative pressure wound therapy portfolio of devices and products that were used in the case studies and clinical research that will be shared today. As a public health researcher, I am excited about any innovations that make advanced wound care more accessible because these technologies have a profound impact on population health and individual well-being. Cardinal Health's Canadian negative pressure wound therapy offerings include the SPED and Pro family of devices that can be utilized across the continuum of care. Each device has a similar design and user interface, providing a consistent experience for both caregivers and patients. The Cardinal Health Pro negative pressure wound therapy device is simple, reliable, and effective. Its intuitive design and compact size make it an easy choice for clinicians. And weighing in at less than half a kilo with a quiet, high-powered motor, it is a popular choice among patients. Other features of the Pro device include 1,000 days of therapy and up to 18 hours of battery life. The Pro to Go kit is a convenient way to ensure patients have no interruption in therapy when transferring across care settings. The kit provides everything you'll need for 10 days of negative pressure wound therapy. Each kit includes a device with 10 days of therapy, 3 large dressing kits, 2 300cc canisters, a carrying case, and an AC power adapter. From multiple dressing sizes to carrying cases and Y connectors, Cardinal Health offers a full suite of dressings and accessories designed to meet your negative pressure wound therapy needs. Cardinal's uniquely patented simultaneous irrigation technology is the only negative pressure wound therapy system that gives you the option of delivering a topical solution into the wound bed at the same time as negative pressure is applied. This therapy helps to reduce bioburden, remove debris, and add moisture to the wound bed, contributing to an optimal environment for granulation tissue generation and healing. I would like to take a moment to introduce the clinicians spearheading efforts to make negative pressure wound therapy more accessible to their patients in our communities. You will hear from Rose Reisman and Susan Chandler, 2 clinical nurse specialists in Toronto. From Nova Scotia, we will hear from Jennifer Jans, a licensed practical nurse with the Victorian Order of Nurses. From Northern Ontario, Jeremy Call is a registered nurse supporting the community of Sioux Lookout and surrounding First Nations communities. And finally, we will hear from Dr. Larry Lavery, a professor in the Department of Plastic Surgery at UT Southwestern Medical Center and medical director of the Diabetic Limb Salvage Program at Parkland Memorial Hospital. After the video, our panelists will join me for a roundtable discussion. You're encouraged to participate and ask questions using the Q&A function.
For many of us, it may be difficult to fully appreciate the patient's perspective as they move across the continuum of care. We're honored to have Mike here today to share his story.
I'm a father of twins. I was, prior to my injury, was working a full-time job at the bank. I was a supervisor over there for the call center. And I was going to school for teachers college. So I was juggling a lot of stuff. And then I got in a car accident and I had to be transferred back home to Toronto. I did a surgery initially in London. And when I did my x-rays upon return to Scarborough or Toronto, I was told that they had to do the surgery again. And I basically, over the past 18 months to 2 years, have split my time between home and the hospital. And I've had 10 to 12 procedures, however you want to count them as surgical or not. And yeah, that's it. The wound is that I had was multifaceted, meaning that there was like lots of moving parts in the wound that could basically, things could go awry at any point. But the major area of concern, what became the infection that I was experiencing, I essentially had to have like an emergency procedure where in which my pin sites after one of the surgeries, I was taking a nap and my pin sites all like exploded kind of thing. And I woke up like, you know, with my leg soaking wet kind of thing. And that led to the emergency surgery where they ended up taking a like massive portion out on the site out of my leg, which I think was as much as 8 inches because of the swelling and all that. Like my left leg is essentially double the size of the right leg, and that basically made for you know, a lot of infectious tissue and retention of liquid. And that emergency procedure created a situation where I had to live with this large cavern in my leg, basically. And that's when the vacuum therapy was introduced. I was on a lot of pain medication constantly. And, you know, living with or dealing with a large lesion that's open in your thigh region, it's not a comfortable thing, regardless of who's taking care of you. Rose was, you know, the best nurse I've ever had. She's, you know, I had a wound care or whatever, and she watched me every day basically and made sure I was good.
So Mike was referred to me to be able to hopefully save his limb, and he had a motor vehicle accident, and then he had an infection in the bone, which we were trying to fight, and he also wanted to be mobile. So we were concerned about possible amputation, and he was too young to do it. So we've tried to promote the quality of life and at the same time provide the medical therapy. So course of treatment for Michael was with a different goals during his 4-month stay in the hospital. Initially, it was mostly drainage, very highly exudating wound, which we were containing using the wall suction, but patient wanted to be mobile. And this is why we needed a mobile unit, which is lightweight, and Cardinal device was perfect for it. Later on in his therapy, we needed a negative pressure to promote granulation, and also to make sure that the surgical intervention which was done, the cleaning of the wound and the tissue healing properly, and then a couple of revisions, incisional negative pressure was used. So this is why we use the negative pressure during Mike's stay at the hospital.
Before we share the outcome of Mike's treatment, Susan Chandler, a clinical nurse specialist, presents on the challenges and opportunities of applying negative pressure wound therapy in community care.
Hello, my name is Susan Chandler. I'm a registered nurse and I am the clinical nurse specialist for wound care at Providence Healthcare, a large rehabilitation facility to the east of Toronto, part of the larger Unity Health network. I hold a master's in wound healing from the University of Western Ontario, and I am also an NSWOC, so a nurse specialized in wound ostomy and continence in Canada, and I am registered and certificated by the Canadian Nursing Association. So when we're considering a patient for negative wound therapy, it's really important that that patient is optimized in a variety of ways to establish good healing. So we will consult as a team to ensure that areas that are determined from pressure injuries will be optimized to reduce pressure. We will have the optimization of urinary and stool management, especially in those patients presenting with larger pressure injuries in their buttocks and perianal regions where they have incontinence of both urinary and fecal. We will also consider their nutritional aspects. So we have dietitians who will advise on their optimizing for various nutritional vitamins to ensure good healing, as well as involvement from physiotherapy, occupational therapy, and also from pharmacy to manage pain. So as you can see, this isn't a one-person approach to wound care. So we have our MDs who are prescribing the wound therapy, and my recommendations go to help maintain that wound as best we can. So when we're considering for negative pressure, we're usually looking at wounds that are larger, perhaps high exudating, and areas where we want to establish quick tissue deposition to fill cavities. We're also looking at wounds that perhaps we want to approximate a little more, perhaps a wound that is dehisced, that we can't heal through primary intention anymore now that the stitches or the staples are no longer holding those edges together, but we're going to heal through secondary intention from the base and the sides. And that's where negative pressure really comes into its own to fill a space. And rather like the adage of wearing a good pair of knickers or even Spanx, negative pressure provides an awful lot of support for a wound, and that can give patients a lot of comfort in their wound management. They feel their wound edges are now stable and not just floating around under a small piece of fabric tape, but also it can help manage pain quite well as well. Some of the challenges we find treating people with negative pressure are that they can get dehydrated if the wound is potentially very high exudating and their input isn't good. And so that is one of the major considerations. We obviously also have a lot of patients that have been on long-term blood thinners, especially for the risk of clotting post-COVID. And one of the contraindications of negative pressure is bleeding, and active bleeding in the wound. So sometimes some of the challenges we have are around staff identifying whether it's healthy bleeding because of new capillaries being deposited in the wound, the condition called angiogenesis. That's what we want to encourage in negative pressure, but sometimes it's difficult to discern whether that is a positive outcome or more of a negative because perhaps they have a higher bleeding risk. So a lot of my role is around education of the contraindications and the challenges of negative pressure. We're very lucky our negative pressure systems are small and lightweight. They can be utilized well by the patient in a little carry bag. They can be taken to the gym for their rehab. So they're not stuck in bed as they are often in an acute setting where wall suction is utilized. So these systems are very user-friendly, but at the same time, we want to keep those negative pressure dressings intact. And so they have to be robust enough to work on the rigors of rehabilitation when they're sat on a bicycle, or they're perhaps doing parallel bars, and they're having to have the tubing well attached so that we're not having it dangling where it could be a trip hazard. So there are lots of considerations, not just around sort of the wound healing, but to keep that patient safe and to encourage that therapy. It's really important for us, certainly in rehab, for patients to be active and mobile in their healing process. But equally for any patient with a wound, it's really good to get them active, because in that activity, they're offloading areas. And even if the area isn't pressure related, what we're doing by mobilizing is encouraging good blood flow, good oxygenation by utilizing their lungs. We're encouraging the reduction of edema by utilizing muscles and pumping away any extra intracellular fluid. So keeping people moving is one of the sort of real tenets of nursing anyway, because we don't want to add to any pressure, injury, compromise, but certainly for negative pressure, it really helps too.
In Nova Scotia, licensed practical nurse Jennifer Jans sees many benefits from negative pressure wound therapy in the patients she treats.
So I'm Jennifer Jans. I'm a licensed practical nurse in Nova Scotia, and I work in community-based care. So delivering delivering nursing care out in the community in people's homes or wherever it is they reside. We see a variety of settings. It's really quite exciting by times. I did have a client recently within the last year who had quite a life-changing decision to make. He was diagnosed with a AAA, so an abdominal aortic aneurysm, and was given the option for a surgical intervention on that. And it took him a long time, I think, to decide, a long time, relatively speaking, to decide whether he wanted to go ahead with that surgery, because he was really considerate of the risks to his ongoing health. And he has quite an active outdoor lifestyle, and he didn't want to risk his ability to continue to engage in those activities. You know, his life may be extended, but if he couldn't engage in the things that really made his life worthwhile for him, he didn't want the surgery. Ultimately, he did accept the surgical intervention and was sent home with just a midline incision. So it wasn't long before we realized that he developed quite a substantial seroma. His abdomen was kind of like a waterbed, and it did compromise the closure, and which dehisced, and I was able to see it almost in action. I ended up seeing him twice that day in the community, once to assess the hole that he told me about when I phoned him originally, and then again after I'd gone and picked up a pump and returned to his house to install that. After getting doctor's orders, of course, a second hole had opened up, and he drained substantial amounts of serous fluid. So we applied the pump to him, completely cognitively able to manage the therapy on his own in between visits. So that was fantastic. A lot of teaching was provided in that first visit to both the client and his spouse, and they managed it quite well. And we gave him some coaching actually on nutrition and all the patient factors that he could manage on his own to contribute. So, you know, our contribution was wound care and providing this negative therapy or negative pressure wound therapy. And his contribution was to manage his nutrition and make sure he was getting enough protein. He has diabetes as well. So we were coaching him on managing blood glucose to really make sure that he was doing all that he could to promote successful healing. And surprisingly, despite the crater in his abdomen, he was healed and off therapy within about a month. So that was fantastic. He went from being very skeptical about having surgery at all to going through this whole process, and he was reluctant to accept the negative pressure wound therapy when his doctor had recommended that when I spoke to him about the dehiscence. So he was quite pleased that there was a role that he could play in his own health, and together it was a really nice teamwork effort, and he was able to resume his normal life relatively quickly. Often the home environment can be a factor, whether people really understand why we're applying the therapy, and whether they're able to manage in between dressing changes. If they have a leak alarm, can we troubleshoot that over the phone? Because we do serve quite a wide area, and sometimes it can take 2 hours to attend someone's home. And that 2-hour window is the time in which they need to be getting the foam out of the wound to prevent an increased risk of infection. So if we're not able to troubleshoot over the phone and people are uncomfortable or unable to remove the dressing on their own and put a backup dressing until we can help them, that can be a real challenge in a rural setting. Transportation issues can be an issue. Really limited income, so people are unable to get to other medical help, or are afraid to call an ambulance because of the cost of it should they need to be transported. That can be quite devastating to some households. So these are all like real life considerations that out in the community we're looking at on a day-to-day basis. Barriers to access. So we need to make sure that we're putting this therapy into a home, onto a person that's well suited to get the real benefit of the therapy. I think the simplicity of the pump, all of the controls are right up front. You're not having to search through electronic menus to find what you're looking for. The on and off buttons are right at the top. Even how to change the vacuum setting is right front and center. So to guide someone through what they need to do over the phone is really quite straightforward. The pumps also come with a quick reference patient guide as well. So we ensure that every home has one of those, so we can guide them to pull that piece of paper out so we know what they're looking at, and we can guide them through it if they're a person who learns better from reading. I did do some over the phone troubleshooting one day where I had the fellow put the phone next to the machine so I could hear what the machine was doing, and it was revving and trying to regain a good seal. So just from hearing that, I was able to then say, okay, go into the box and get this particular type of film, and I want you to reinforce the dressing. And he was able to make it happen. So that was really fantastic. Over the phone coaching can be really effective if you've got the right client on the other end of the phone, and they've been given appropriate teaching in the home as well. They have access to backup dressings or extra film to reinforce dressings.
New technologies can help overcome some of the challenges in community care. Jeremy Call will share the benefits of the CardinalHealth Pro2Go, a disposable negative pressure wound therapy device in indigenous communities.
Hi, I'm Jeremy Call, registered nurse and wound specialist for the Sioux Lookout Area Primary Care Team. I live and work in remote Northwestern Ontario, where I provide advanced wound services to Sioux Lookout and the surrounding remote indigenous communities. My experience with the CardinalHealth Pro Pump is a positive one, and one of the main reasons for that is that it's very reminiscent of a traditional vac. And so for a population of professionals, mostly transient professionals, they could be coming from Toronto or anywhere else across the province or even outside of the country to service the community members up north, a lot of agency staff. So, being able to keep up on the level of education required for negative pressure therapy, if we're using something that's not, not familiar to people, it can be a challenge. So I specifically chose the CardinalHealth Pro Pump because the foam and the drape are very familiar to anybody with even minor experience applying a negative pressure dressing, and the pump settings itself are very easily followed and achieved. So I think the main thing was keeping up on the level of education for the transient staff and being able to pick a product that would be familiar to them. For me, working in a remote area and I'm trying to help support patients from a distance, I can literally send the pump up north with very little instructions and be able to achieve the staff being able to achieve putting the dressing on, applying the dressing. Some of the challenges we face here in the remote Northwest is accessing negative pressure wound therapy. Traditionally, our patients would access it through a provincially provided home community care program, Unfortunately, through geography, our patient population, that would benefit from the negative pressure therapy mostly lives in the north, remote north. And as such, they aren't able to take a capital cost equipment like a traditional vac pump back home with them for fear of that product not coming back to the provider. So by using a Cardinal Health Pro pump, not only is the dressing familiar to staff who have some experience with negative pressure therapy, but the pump itself is more cost effective and can go home with the patient for healing. Our patient population, if they wanted to access vac or negative pressure therapy in a traditional sense, they would have to live in Sioux Lookout for weeks on end to receive that service. And patients have jobs, they have children, they have families back home that need them, and really they're opting not to have potentially a limb-saving therapy for all of those patient factors that end up making them need to go home. Patients who aren't accessing negative pressure therapy would be applied a traditional dressing, standard wound care using best practices, but they aren't accessing the advanced therapy. Our rates of amputation are there's a study that was published by Lone et al. In 2017 in the Journal of Rural Medicine, and they articulated that the estimates of our limb loss are upwards of 7 times that of the rest of the province.
We all wish for success stories for our patients. Mike and Rose recount the outcome from their patient and clinician journey.
At one point, it was like I was in care, and they could abruptly wake me up and tell me that they're gonna take me to surgery to amputate and things like that. I saw my leg I saw my legs look like they were on the verge of exploding from swelling and things of that nature. And like I said, at the worst point, I think the lesion was 8.1 inches or something like that. And when we finally got it to close, I don't know how much you've spoken with Rose, but we got it down to halfway, 4 inches or something like that, and then it was not working anymore, and then they switched it over, and basically put me on the big machine, and then Chemiker essentially took my leg from one side to the other and closed it, and I did some miracle work basically. But at that point there was constant monitoring. Rose was changing a full leg length dressing daily, putting meta honey and all different types of stuff on it. So that's kind of where we're at. And everything closed. It's still really tender, really painful. I have lots of scar tissue, and my therapy is focused on removing the scar tissue and going from there. It was pretty crazy because Rose was my person. It went to the point that so much was going on that nurses kind of became apprehensive to work with me, in fear of aggravation or whatever, in terms of doing something to the wound that they're not familiar with. So it became Rose was at my bedside, almost for an hour or two every day, basically educating a slew of nurses. And the medical system in Canada has a lot of pitfalls from my experience, but it takes nurses like Rose to basically go above and beyond and show everybody that things can be done and they're not actually that hard, even though they may be intimidating or new techniques based upon what they usually do in their daily routine. But yeah, Rose was teaching and showing nurses every single day, every step of the way, regardless of what stage of the injury I was at. She was great, did absolutely everything, and to the point where I still talk to her, multiple times a week.
What I liked about negative pressure for Cardinal, that it's light, it's portable, it's very easy to teach, and it was very patient friendly because when he was going on the wheelchair around the hospital, and if the canister gets full, he could change it himself. In addition, the connection between the spout and the canister was, we were able to use it with the other devices. So if we needed to switch from one to wall suction, it was very easy. So I like this feature as well. And also economical. This pump was very economically acceptable.
Just as a last sort of note, I would recommend, if anybody is weary of proceeding with this kind of therapy, they should at least give it a try, because it gives opportunities where they weren't necessarily visible before, right? So that's pretty much it. And I would say that without vacuum therapy, I wouldn't have a leg, and my life would be very different. Because of the success of vacuum therapy, I was able to transition to get a full knee replacement, and the doctor's happy with the results, and thinks I'll be out of a wheelchair and walking, right? So to come from a situation where you're supposed to lose your leg to be up and walking, it's a big road. But I know there's a spectrum that the vacuum therapy is capable of, and not just preventing infection, speeding up healing and stuff like that. So as an alternative, this is where, I would recommend it to anybody to give a shot.
There are many well-established, commercially available negative pressure wound therapy systems in use today, but it is difficult to find direct comparisons of their performance in the literature. Here, Dr. Larry Lavery shares an overview and results from his prospective randomized trial.
My name is Larry Lavery. I'm a podiatrist and a professor in the Department of Plastic Surgery at the University of Texas Southwestern Medical Center in Dallas, Texas. Today, I'm going to talk about a new clinical trial that we've conducted to evaluate negative pressure wound therapy and negative pressure wound therapy with simultaneous irrigation. One of the reasons we became interested in this area was because diabetic foot wounds, especially complex wounds, are extremely common. They often lead to amputation, reinfection, and readmission to the hospital. And this approach, we think, provided an advancement in a technology that has already basically changed the way we treat complex wounds. The objective of the study was to compare negative pressure wound therapy with continuous irrigation with a Cardinal negative pressure wound therapy device without irrigation, and kind of the traditional KCI negative pressure wound therapy approach. We used a standard application of 125 millimeters of mercury, and in this study we used a continuous irrigation with normal saline, a constant flow rate of 15 cc's per hour. This was a study that we included patients that had complex infected wounds. The vast majority of patients had diabetes. So these are people that required surgery, and in our institution would be the traditional patients that we would use negative pressure wound therapy on. This was a randomized clinical study with 90 patients, 30 in each of the 3 treatment arms. We evaluated patients for 12 weeks. The primary outcome, which is the standard FDA outcome for wound studies, was complete wound closure. The secondary outcomes were time to wound closure and adverse events, primarily foot-related hospitalizations and foot-related infections, and patients that required subsequent surgeries. Essentially, all of the primary and secondary outcomes, there wasn't a difference between the 2 negative pressure wound therapy groups and the negative pressure wound therapy group with simultaneous irrigation with normal saline. Across treatment groups, we had very similar length of stay, exposure to antibiotics, and a very low rate of recurrent infections, hospitalizations for all cause, and hospitalizations that were foot related. So while the proportion of wounds that had complete wound closure were higher in patients that received negative pressure wound therapy with irrigation, there wasn't a significant difference across the 3 treatment arms. So I think there are important limitations of the study. The first and probably the most important is this is a small study meant to collect preliminary or pilot data. So while there weren't any differences in wound healing, this study really wasn't powered to detect those differences. The sample size wasn't robust enough for us to see that difference. I mean, otherwise, I think the strength of the study are that it's really the first study that compares negative pressure wound therapy and negative pressure wound therapy with irrigation in complex wounds. If we take this preliminary data and use it to plan a prospective study, we would need about 180 patients in each treatment arm to measure the differences that we observe between just the Cardinal traditional negative pressure wound therapy and negative pressure wound therapy with simultaneous irrigation. So, that is certainly an achievable goal in the future, and a small enough sample size that most studies will be able to execute that. Perhaps a novel approach in the study was we compared kind of traditional market leader in this space, the KCI negative pressure wound therapy product with the Cardinal Pro negative pressure wound therapy device, the traditional approach with no irrigation, and found no difference in those 2 approaches in the primary outcome or any of the secondary outcomes.
Our speakers' determination and resolve are reflected in the devotion they show to patient-centered care. When faced with barriers to accessing a life-saving therapy, our speakers challenged conventional wisdom by trying something new. In addition, Dr. Lavery presented clinical data demonstrating that one-touch portable canister-based technologies are as effective as traditional market-leading devices. Combined, these patient stories and clinical data give us hope that one day all patients like Mike will receive the best possible care in their communities. At Cardinal, we strive to be essential to care so that no patient should ever have to wait. Together, we can and will heal more. Now I'm pleased to welcome Rose, Susan, Jennifer, and Jeremy to join me for a roundtable discussion. Please keep asking questions using the Q&A function. So to start off with, I think everybody really enjoyed hearing these patient stories. So I'll start off with Rose. What a fantastic outcome. How is Mike doing? Do you have any updates for us?
He's doing well. He had some other surgeries not related, and he is living his life. And fortunately, he is not in the hospital, and he is with his kids, and he still have both legs, which I think it's a good outcome, right, Susan? Susan also know Mike.
That's great. And Jennifer, your case was also very interesting. Could you give us some more information, and how is your patient doing now?
I can't. I do know that he hasn't been readmitted on service, so that's a good story in itself. But that was a struggle for me when I first got into nursing. Is you have to be comfortable with not knowing the end of the story. But he was doing quite well when I left him on his own, and so that was great. I wanted to just say one thing that didn't kind of make the final cut was the accessibility of the pumps, and in particular with that fellow's case. So our agency actually purchased the pumps from CardinalHealth. So we've got them available in both of our storerooms in the Annapolis Valley here. So when we identify an issue, accessing that therapy in a timely manner is really quite easy. It's the pumps are only as far away as the trip to the storeroom. So in that fella's case, that was fantastic. You know, during the course of just that one day, he had 2 large dehiscence areas. They were probably 4 or 5 centimeters deep, And, had we had to wait for a pump to be couriered from another company, particularly in rural Nova Scotia, I've seen that take upwards of a week. So we were able to support him really well by actually having quick access to the product.
All right, great, thank you. And so kind of along the same vein of accessibility, Jeremy, we had a question from the audience on who pays for the pump. So is it home care versus primary care? Was it your clinic? Does First Nations and Inuit Health Branch pay for it? Any comments on that?
Yeah, that's a really good question. It's a really challenging one to answer, unfortunately, because there's no really good way to cover this product. We have a federally supported population and a primarily provincially funded program. So unfortunately, very fortunate that the industry, like Cardinal Health, was very generous and able to provide the pump for a trial on a few patients that I've seen. But unfortunately, there is no sustainable model yet to provide disposable negative pressure to our population. So that's one of the things that the industry can do to actually help our patients is support circumventing those barriers and that are woven into our systems and providing direct access to essential products that aren't easily covered. Supporting individual clinicians and wound champions like me also help to advocate at high levels for access to essential products and advanced therapies that, would otherwise not be covered in light of equitable access. So supporting the quality research to back the use up and the socioeconomic impact of their products will help, because without that data, we can't advocate to agencies like mine where we're not specifically funded for wound care. We don't incur any specific costs for wound care. That maybe a cost benefit analysis might not be sufficient. Like patient stories and sharing at this point helps all that.
Thank you. And then there is also a question as to whether there was a product rep in the North, and there is, and they will be in the booth after this talk. So if anyone has an interest in meeting the Northern rep, we will have them in the virtual booth. So Susan, I know that you've had, and we've talked several times in the past about how you've been very successful with patients managing negative pressure wound therapy independently. So have you had any patients report inconvenience in dealing with negative pressure wound therapy on their own? And how independent could you say a patient might be?
So I still think they need eyes on. They need eyes. It's an advanced wound therapy. There's lots of contraindications for any negative pressure device, and wounds that require negative pressure are usually quite substantial. So they do need regular eyes on from a clinician, just to sort of mitigate any issues. But the patients that we've sent home with negative pressure, and even in the hospital, have become very sort of self-aware of their wound care and their management, and they've, really participated well. The inconvenience tends to be, it's amazing how adaptable people become. One young lady was having problems with the tubing being too long. She found a bobby pin and a little clip, and she'd sort of wrapped it all up and just made this sort of MacGyvered this little carry-all that added to the case just to keep it tidy, and so it wasn't so visible. But for going home, I found when people have had to reinforce film because there's been a leak, because of the education and because the tip sheet that Jen was referring to so beautifully in the video, it's so user-friendly. You can usually talk people through it, or they have a very good sort of concept of what needs to be done. And that sort of speaks to going to really involving your patient in their wound care journey, so that they are aware of the products that are being used, how they're being used, and how it all fits together. Because then potentially they can sort of circumvent any issues as they come up. They get to know the sound, as Jen was saying, when it starts chugging, oh, something's wrong. So, and then they can go to their checklist or perhaps phone their clinician when they're at home. So for the most part, no, there is always that area of people being apprehensive about negative pressure. And certainly for the when you first put it on, because they hear the word vacuum. And if you try and steer away from the vacuum and try and make it into negative pressure, it's less scary. And then also when you've got the dressing all ready to go and to actually put the negative pressure on, get them to put their hand on the foam. So as it descends, they feel as it descends, and they sort of get so amazed by oh, this is happening. It takes away that apprehension of this vacuum going on the wound, as it were.
Great, thank you. So Jen, do you have any thoughts on patient independence and managing remotely?
These pumps are really quite lightweight and portable. I really like the way they function in the community. We have had a couple people who've been frustrated, I think not so much with the pump or the therapy itself, but their situation as a whole. And sometimes they'll take it out on the nurses. And sometimes we recently had a fellow who took it out on the pump, and he was treating it so harshly that we had to replace his twice because he had jammed the charger in and bent the prongs, and he just had enough of all of this. And, you know, after I spoke with him, there was definitely a larger issue going on, but that's sort of how he was able to express that to get somebody's attention, is, you know, to be rough on the equipment. So, yeah.
That's sort of funny. That reminds me of another story I heard from a US clinician who works in rural communities, and her patient was a farmer with dementia. And he felt that the motor was running too rough, so he kept taking apart the pump. Yes. And so they had to eventually maneuver things around so he couldn't get at it quite easily, because they kept coming over and finding him with his tool set out and trying to fix it because it wasn't sounding like a tractor.
Exactly. Yeah. Yeah. And these are very real situations that you walk into in the community. And it's such a privilege to work in people's home spaces where you get a sense of what actually is going on in their lives and who's around and what kind of supports they have and what challenges they have right in the home that might decrease the effectiveness of whatever treatment you're providing. And like I say, it's a real privilege to work out there. But in my client's case, that privilege ends like when they're discharged, and then you have to be okay with not knowing the end. So,
yeah. So Rose, what do you think the most important features are for your staff and the patient population you treat when considering negative pressure wound therapy?
So I liked about this particular pump. First of all, it's light, and then it's quiet. Usually I had questions from the patients, oh, it's quiet, I don't hear any noise, it's not working. About independency, my background, I was born in Russia, and in that country you have scarcity, so you don't have a variety of pumps. And actually there are some people who cannot afford to go to any other pump, and I had a patient who didn't have coverage and was on Cardinal pump, and it was too quiet, and they were using it by themselves. It wasn't my patient per se, they just found me on the internet, and since I speak in Russian, they reached out. So the pump was very quiet, and it's very easy to maneuver, and it's very easy to MacGyver. So they were able to use equipment easily, and they found that the pump was very nice.
Great, thank you. Jeremy, same question for you. What are your thoughts on the most important features for your staff and coworkers, colleagues, and patients for negative pressure wound therapy?
Absolutely, thanks for your question. I touched a little bit on it in the video, but one of the things is just having some familiarity to the product. So historically accessible equipment has a similar drape or similar foam. It supports a transition, like a transient working population. I think that vendor support is super important. So ease of access, on the spot clinical support for implementing a new product effectively and training staff appropriately. I think those are super helpful, and just some variability in the product. So being able to tailor the settings for the patient, for example, the pressure setting or an intermittent setting to achieve a different result.
Okay, thank you. And so for our last round, again, I'll open it to all of our panelists today. I'll start with you, Rose. Do you feel that negative pressure wound therapy is underutilized? at least in your community and for your patient population?
In my patient population, it's not underutilized because I utilize it whenever it's needed. And there's such a variety of negative pressure therapies, which we can use. And I use it under compression, and I use it for all types of the wound. And yes, sometimes nurses say, oh, there is no drainage, so we don't need negative pressure, which usually makes me angry because negative pressure, it's not a collection device. It's a healing therapy. And I try to explain the nurses, we're not using it to collect the fluids, we're using it to heal the wounds.
So Jeremy, do you have anything to add?
Totally agree with that. I was thinking like about this question and knowing that there's limited resources for negative pressure, like in both the acute, I've worked in the acute care and the community setting, and the limited resources that are available are arbitrarily allocated to patients, often based on drainage volume versus indications for use or evidence of healing. And for that reason, I would argue that here, at least in Northwestern Ontario, it's underutilized.
It's a great response. It's a wonderful thing to think about. Jen, do you have any thoughts on underutilization of negative pressure wound therapy?
I actually think we use it quite frequently here. Either clients are discharged into our care from our regional hospital, and we've got a lot of orthopedic surgeries that happen there, cancer surgeries, vascular surgeries. So the surgeons utilize it wherever it's appropriate. And we actually have implemented it in the community as well. From our perspective, you know, we see an issue going on and say, hey, I think we could do some good work here with this, because it helps speed healing, get people off service, so we've got more room to take more people on, because we're having a terrible healthcare crunch in Nova Scotia right now. It's a huge problem. So the faster we can get people fixed up and back to their lives, the better. So we use it wherever it's indicated.
Great. Susan?
We have some challenges with when we send people home, just because often we can't send them home on every machine that we have, because some of them are reusable and quite costly. The Pro2Go kit really fits this sort of need, where we can send people home with a kit. And then they have replacement dressings for for the 10-day period. That really means that there's no gap in provision of care, because sometimes it's very hard when you make the case for negative pressure for your patient, you get them on it, and then you have to send them home on a more conventional dressing while they wait list for a sort of negative pressure in the community. So the Pro2Go kit certainly meets that need really nicely. So yeah, that's why we helped onboard it. It was quite nice.
All right. Thank you all so very much for joining us today, sharing your stories, sharing your expertise. Believe it or not, we're actually at time. We're ready to wrap up here. And so I want to thank the audience for taking the time to spend with us and to also learn about our devices and share your questions. Please remember to submit the survey that's in the auditorium area. Let us know how we did. We really appreciate your feedback. And also, please come by and visit us at Cardinal Health's virtual booth. We're happy to answer additional questions. There are additional representatives from Cardinal Health, and we can walk you through our product portfolio of devices and so forth in more detail. So thank you again all for joining us. Enjoy the rest of the conference, and thank you again to all of our clinical participants for joining us today.